This is also very important. Question भी कुछ एक पूछो। हाँ Rubina, what's the problem? Hello, 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 hello. Is there any question?
No, ma'am.
Can we start the lecture?
Yes, ma'am.
Okay. Okay. So today there is another. You know that we are continue discussing the medical disorder in the pregnancy. This is again a very important neurological disorder. Among the neurological disorder, this is a very important regarding the pregnancy, because this is quite common. You encounter the this type of the patient, and this type of the topic can come in the MCQs, PCQs, and in the as well as in the short essay questions. So on the examination point of view, this is also important, and clinical point of view, this is also important. So you must know how to manage the epilepsy in the pregnancy, the management of the epilepsy. Epilepsy, as you know, this is a disease of the young age group. Usually, young age, 30% of the women with the epilepsy are in their reproductive age group. So, approximately 6 in 1,000 pregnancies are complicated by previous history. Either the patient are suffering from the epilepsy since birth or since childhood, or patient have the current history of the epilepsy in the pregnancy. So it makes the most common pre-existing neurological condition, that is the complicating the antenatal care. We will discuss someone is raising the head, but we will discuss this later in the end of the lecture. I will answer you in the end of the lecture, okay? So the incidence, we discussed the incidence, that means 6 in 1,000 pregnancies. यानी 1000 में से 6 औरतें आपके पास आएंगी एपिलेप्सी के साथ. So you must know about the epilepsy. What is the classification of the epilepsy? As you know in your medical medicine, that there may be the generalized epilepsy that include the tonic, clonic, seizures. There may be the presence or absence myoclonic jerks, partial or focal seizures, with or without loss of consciousness or secondary generalization. Then there may be the temporal lobe seizures. This is also the form of the partial seizures. What is the pathogenesis? Why it occurs? Usually it is idiopathic. There is no cause has been found for the epilepsy. 30% of the patient have the familial. This is a familial disorders and may run in the families. Her mother, her sisters, her father may be suffering from the similar type of the disorders. So 30% there may be the family contribute to the occurrence of this epilepsy. Then there may be the secondary epilepsy, that may be the because of certain tumor, trauma, surgery, previous surgery, particularly if there is any type of the tumor in the brain or any other lesion in the brain that will lead to the surgery, surgical removal, and like the meningiomas. There may be the vascular malformation, particularly the arteriovenous malformation, which is quite enlarged in the pregnancy. And this is this arteriovenous malformation that lead to the epilepsy. This is known as the epilepsy of the pregnancy, because this arteriovenous malformation, it is enlarged during the pregnancy, will leading to the epilepsy. Then antiphospholipid syndrome, you can also call this syndrome is also leading to the other problem in the pregnancy, like the recurrent abortion, like the intrauterine growth retardation, like it may lead to the preeclampsia, hypertension, and it may lead to the intrauterine fetal death, the preterm birth. So this is apart from these problems, the antiphospholipid syndrome may also lead to the conversions and the seizures in the pregnancy or the epilepsy in the pregnancy. Then what is the differential diagnosis of the seizure? You must know the differential diagnosis of seizures during the pregnancy and postpartum. सबसे पहले जो important आएगा, that is the eclampsia. After the eclampsia, there may be all the causes which occur outside the pregnancy could occur in the pregnancy. So you must know, this is not necessary कि अगर pregnancy है तो सिर्फ eclampsia ही हो सकता है. There may be all the other causes of the seizure which could occur outside the pregnancy can occur in the pregnancy as well. So there may be the intracranial infections like meningitis, encephalitis, the brain abscess, the cerebral malaria, metabolic disorders like hyponatremia, hypoglycemia, hypocalcemia, liver and renal failure that will again lead to the certain metabolites in the pregnancy, anorexia and the alcohol withdrawal. And then there may be the vascular diseases like cerebral infarctions, subarachnoid and cerebral hemorrhages, hypertensive encephalopathy, cerebral vein thrombosis. All these vascular problems will lead to the fits and the seizures. Certain drug toxicities. Certain drugs also may lead to the fits and seizures in the particularly the local anesthetics drugs. Lidocaine है, वो लोग चाहे IV किसी ने गलती से दे दी या फिर sometimes subcutaneously or intradermally or the subarachnoid space में जब spinal या epidural देते हैं, that also may be higher doses may lead to the fits and seizures. Then the tricyclic antidepressants, they also will lead to the seizures. Amphetamine, lithium, these also contribute to the seizure. And sometimes there may be the pseudo-epilepsy. The cause may not be known as, seems to be like an epilepsy. So you must know the other causes of the seizure in the pregnancy. That means that apart from the eclampsia, all the other causes which occur outside the pregnancy could occur in the pregnancy. Why we are worried the epilepsy? What is the main reason for which we are worried regarding the epilepsy? This is mainly the effect of these drugs which are using to the epilepsy to control the seizures. So the effect of the anti-epileptic drugs on the fetus as well as on the newborn. Teratogenicity, that will lead to the, not only these causes the sedation and other problem to the newborn and the fetus, but this causes the teratogenicity. That is a very important aspect of this anti-epileptic drugs. So major and minor congenital malformation and characteristic dysmorphic syndromes. This malformation will lead to the certain type of the syndromes. And there may be the neonatal withdrawal effects of these drugs. There may be all these drugs may particularly lead to the vitamin K deficiency. So there may be the hemorrhagic disease to the newborn. There may be the hematoma formation, cephalohematoma formation, or there may be the bleeding diastasis to the newborn. There may be the developmental delay, or there may be the behavioral difficulties to the newborn, as well as in the childhood. The incidence of the congenital anomalies significantly increase among the offspring of the epileptic mother. जो background risk है वो 2 to 3% congenital anomalies का है, and but in the with the anti-epileptic 2 to 3-fold increase the risk of the congenital anomalies. Anti-epileptic drugs are responsible for most of all this increase in the congenital anomalies. The benefit of seizures. अब देखिए कि ये these are the therapeutic aspects which we are discussing. The what are the therapeutic aspects? यानी जो हम medicine दे रहे हैं उसके aspect क्या है? उसके what are the advantages of this medicine and what are the disadvantages? The main one disadvantage of this is that the effect on the fetus and newborn, that is the teratogenicity, congenital anomalies, neonatal withdrawal effect, vitamin K deficiency, and the developmental delay. Other aspects are that there is a 2 to 3-fold increase risk of congenital anomalies by using these antiepileptic drugs. So the benefit of seizures control during the pregnancy outweigh the risk. अब हमें खुद ही देनी है वेटेज किसको के whether we should continue the drug to control the fits to the mother or we compromise the fetus congenital anomalies. Polytherapy with more than one anti-epileptic drug carries the greater risk to the fetus than the monotherapy. These all aspects should be assessed prior to the pregnancy. Although the certain anti-epileptic drugs are more strongly linked to the particular congenital syndromes or the abnormalities, एक syndrome होता है that is known as the phenytoin identroid syndromes. That is most commonly associated with the phenytoin sodium. That is particular syndrome. So the certain anomalies are linked with the certain type of the drugs. There may be the significant overlap that not only the one, there may be the more than one drug which we are using that may also cause the multiple anomalies to the fetus. Not only the one anomaly, that this is a phenytoin identroid syndrome caused by the phenytoin sodium, then the other anomaly may be caused like nasal hypoplasia or other cardiac anomalies may be caused by this sodium valproate. So there may be the different overlap of the drugs that may cause the multiple anomalies to the fetus. The first line agent can all cause the anticonvulsant syndrome. What are the effect of the epilepsy on the pregnancy? Epilepsy pregnancy को क्या करेगी? The most cases सबसे ज़्यादा जो important हम कहते हैं कि pregnant Smith in the fetus, particularly in the fetus, is may lead to the congenital anomaly. While in women, usually there is no effect on the frequency of the seizures. अब देखिए, this depend. There may be in some women, not all women. In some women, there is no effect on the frequency of that. There is one study which has been conducted in the Europe. They compare the first trimester seizure control. They have found that 64% of the female remain unchanged throughout the pregnancy. Means there is no increased frequency of the seizure or no decrease in the frequency. While 17% female had an increased frequency of the seizures. 16% having decreased frequency of the seizure in the pregnancy. No relation to the seizure type or the course of the epilepsy during the previous pregnancy. It's not related. कि previous pregnancy में बहुत ज़्यादा seizure हुए थे तो अब भी ज़्यादा होंगे. There is no relation. The risk of seizure is the highest in the peripartum. 3.5% of the pregnancies were complicated by the intrapartum seizure. This we will discuss in the management during the intrapartum period. Why in the, yes, we will answer you in the later on at the end of the lecture. The risk of seizure is the highest peripartum. 3.5% pregnancies were complicated by intrapartum seizure. This will I discuss that why in the intrapartum period there is an increased frequency of the seizures. Unlikely to have a seizures in the pregnancy, seizure-free. Seizure-free for many years unless she can discontinue her medication. Likely to deteriorate in the pregnancy in a poorly controlled epilepsy, especially those whose seizures frequently exceed once a month. If the patient's seizure exceed once a month, usually we are not going to advise these ladies to become pregnant because it means if she had the seizure more than one in a month, that means that her seizure control is not good and she may require the polytherapy, and you know that a polytherapy is more dangerous for the fetus as compared to the monotherapy. Likely to increase the seizure in frequency while women with a multiple seizure type, यानी focal भी हो रहे हैं उसको generalized भी हो रहे हैं, तो this will lead to the increased frequency in the seizure. Maternal death, there may be the common maternal death, indirect maternal death. This is a common cause of the indirect. Direct maternal, obstetric maternal death, जिसको कहते हैं जो obstetrical reason की वजह से हो रहा है. So there may be the indirect death, that is 5 to 10 per million maternities are the 5 cases per year. Usually जो cause होता है, that is a aspiration in the fits. Aspiration pneumonia, inhale कर लिया कुछ सीजन में, so this leads it. Epileptic fits may be fatal in themselves. Usual reason जो epilepsy या fits में होता है ना patient का, that is a aspiration. So we have to keep the patient in a good position and prevent anything to be taken by the mouth, so there may be nothing to go into the lungs that will lead to the sudden death. Then there is the SUDEP. SUDEP is a sudden unexplained death in the epilepsy. This is also common. देखा गया कि patient घर पे बिल्कुल सही थी, all of a sudden they have been found that she is dead. And what is the reason? It's still not known. In 1 into 500 women year outside the pregnancy, uncommon in those with a good seizure control. The patient is this is usually occur in the seizure. If the uncontrolled seizure, the SUDEP could be common. It is not known whether the pregnancy increased the risk factor, high frequency, high number of antiepileptic, low IQ, early onset of the epilepsy. Reason for deterioration in the seizure control, क्यों हो रहा है controlled seizure during the pregnancy? Maybe the pregnancy itself, poor compliance. ज़्यादातर जो females होती हैं, they have the fear that these drugs may causes the teratogenicity, तो वो खुद ब खुद जो है ना छोड़ देती है medication because of the teratogenicity. So they, with the withdrawal of the drug or the discontinuation of the drugs because of the fear of teratogenicity, and they reduce the dose of the antiepileptic, or they have the single antiepileptic drug. So that's why there may be the reduced this increased frequency and because of the reduced drugs. Decreased drug level. This is particularly nausea and vomiting in the early pregnancy. वो जो ले रही है वो पूरा निकल रहा है, तो उसकी ड्रग लेवल उतनी नहीं पहुंच पाती थेरापेटिक लेवल पे. That's why there may be the increased frequency of the seizures. Decrease the free drug level because of the there are the certain protein bound, because all these drugs are the protein bound, and there is an increase in the proteins. That's why the drugs are mostly bound to the protein, and you know that the therapeutic level is only achieved when there is a free level of drugs available in the serum. So all the drugs, mostly the drugs are bound to the protein and they lost their efficacy. Lack of the sleep toward the term during the labor or at the time of the term. Usually this is a normal habitats of the females, that in the end, because of the pressure of this fetus, enlarged belly, and there are other minor problems that will lead to the sleeplessness to the female, and that you know that the sleeplessness is one of the trigger factor for the occurrence of the seizures, and this is quite common in the last trimester of the pregnancy and even during the labor because of the labor pains. Lack of absorption of anti-epileptic, you know that in the pregnancy, as we discuss in the physiological changes in the pregnancy, that there may be the decreased absorption of delay absorption because the food or other things remain longer time in the gut. So there may be the delay absorption of the drugs as well as other things during the labor as well as in the pregnancy. And no doubt the hyperventilation that is quite common in the labor and the pregnancy, that is a reason for the epilepsy. Now, what is the effect of epilepsy on the pregnancy? The fetus relatively resistant to the short episodes of this is the effect of the these are the effect of on the mother, effect of the pregnancy, effect of epilepsy on the pregnancy. Now it's a effect on the fetus, relatively resistant to the short episode of hypoxia, and there is no evidence of adverse effect of single seizure in the fetus. अगर एक सीजर हो रहा है तो उससे इतना ज्यादा आपने एक्लेम्सिया में भी देखा होगा कि usually the baby are alive, they are only died if they have the recurrent seizure or this is the what we call this the recurrent seizures. Some have documented fetal bradycardia during and after the maternal colonic and tonical convergence, but cerebral damage in the long term is not a feature. There is no increased risk of miscarriage or obstetric complication in women with epilepsy unless a seizure result in the abdominal trauma. Increase अगर कोई female औरत जो that is the having the epilepsy, she developed the seizure and she fall down on the floor and her abdomen will be strike on the floor, then that means that there may be the chances that the trauma could occur to the fetus. Sometimes there may be the cephalohematoma or other the bone fractures or other complication could occur. Otherwise, there is a least complication. There may be the risk of the congenital anomalies जो बार बार हम लोग discuss कर रहे हैं. Status epilepticus is dangerous for both of there. If there is a repeated seizures to the mother, then she has no control. Then this may be the dangerous for the mother. Is they may cause the various type of the trauma to the mother, various type of the trauma to the fetus. Patient may be fall down on the floor, and that will lead to the trauma. And there may be the mother may have the aspiration pneumonia. Mother may have the adult respiratory distress syndrome, or she may inhale and choked and they may do that death. So it should be treated vigorously. Child developing the epilepsy, there is an increased chance. This may be the familial. So if either parent has the epilepsy, there is a 4 to 5% chance. If there is a previously affected sibling, then there is a 10% chance. In one parent hai or sibling hai, to 10% chance hai. If both parents have the epilepsy, then there is a 15 to 20% of the chance that the child may develop the epilepsy. If she herself had onset of epilepsy before the age of 10 years, again, if the mother is suffering from the epilepsy, ये हमने पहले भी discuss किया है, कि if the mother is suffering from the epilepsy in the childhood period, then again there may be the chances of her offspring suffering from the similar type of the problem. What are the drugs which will lead to the teratogenic risk? All the drugs which crosses the placenta and all are the teratogenous. The drugs which are commonly used in the epilepsy are phenytoin sodium, primidone, phenobarbital, carbamazepine, sodium valproate. ये जो lomotrigine, this is a new drug and has been considered that this has a somewhat less effect teratogenic as compared to the other and having the good control on the episode. Topiramate, ये जो लेविटायर एसिटाम है, ये this is also a new drug and this also has a good control on the epilepsy. What are the major malformation which occur because of this anti-epileptic drugs? Usually the neural tube defect. Their neural tube, this may be the N-cave, there may be the hydrocave, there may be the meningocele, there may be the meningomyelocele. So the neural tube defect because they competed the folic acid, the folate. So sodium valproate will lead to the 1 to 3.8%. Carbamazepine will lead to the 0.51%. Other defects are the orofacial defects. Particularly this orofacial defects, nasal hypoplasia, hypertelorism, and frontal bossing, and flattening of the nose. These are the defects which could occur because of these anti-epileptic, particularly the phenytoin sodium, the carbamazepine, the phenobarbital, then the congenital heart defect. This is also quite common in the patient with the anti-epileptic drugs in the epilepsy because of the anti-epileptic ASD, VSD, particularly the phenytoin, phenobarbital, and sodium valproate. These all are the drugs which are commonly used in the epilepsy that causes the teratogenic effect. But we must weightage. We must weighing the advantage with the and the disadvantage of these drugs. Then there's some a minor malformation, fetal anticonvulsant syndrome, dysmorphic features like V-shaped eyebrows, low set ears, broad nasal bridges, irregular teeth, hypertelorism, hypoplastic nails in distal digits, hypoplasia of the midface could be the marker for the cognitive dysfunction. Cognitive dysfunction ये हमने पहले भी discuss किया, low IQ and the low cognitive skills of these babies whose mother are suffering from the epilepsy, and they're using the anti-epileptic drugs. Management. Now this is very important aspect, the management of the epilepsy. As we discussed that all these medical disorders, they have the multidisciplinary approach. This is not a single job of the obstetrician only. This involves the neurologist, this involves the obstetrician who's a particular interest in the epilepsy, the neonatologist, the anesthetist, the epilepsy specialist nurse that she has to look after the female and how to cope with the epilepsy and how to control the fits. Now review the diagnosis. Pre-pregnancy assessment में हमें सबसे पहले important and no doubt that this is the teamwork, and team also include the patient herself, her attendant, or the person who is looking after to this female. So this is a very important that if the patient is suffering from the epilepsy, or she have the history of the epilepsy, or if she is on the epilepsy, or she had the past history of the epilepsy, she should be reviewed from the neurologist to assess the status of the health status of the female, physical status of the female, and what are the type of the drugs she is using, and how many drugs are using, and can she be put on the single therapy, monotherapy as compared to the one therapy? Can we control her fits on the monotherapy? And can we stop the drugs? So the consideration should be given to the stopping the anti-epileptics if particularly in those who are the fit free for at least 2 years. अगर किसी भी patient के 2 साल तक कोई fit नहीं पड़ा है, तो it's a safer that we can stop the drug, particularly in the first trimester. So but there may be the chance of the risk of the relapse 20 to 50% higher for some form of the epilepsy, particularly the juvenile myoclonic type of the epilepsy. Where possible, the treatment regime should be simplified. जैसे मैंने पहले भी बताया, these things we are discussing prior to the pregnancy, means pre-pregnancy assessment. All the patient with the medical disorder should have the planned pregnancy. The pregnancy and the medical disorder should not be accidental, because we assess the status of the female, whether she is cope with the pregnancy or not. Her health will be cope with the pregnancy or not, because pregnancy is a burden. No doubt there may be the certain physiological changes which could occur in the pregnancy. And the other danger is that of the drugs, the medications, which are the teratogenic. They cross the placenta, which type of the drug are crossing the placenta, which are the drugs not crossing the placenta. So the safety of the drug is very important. So where possible, we must modify the treatment regime, and it's better to simplify to the single anti-epileptic agent as compared to the with the lowest effective dose to minimize the risk of the congenital anomalies. But it is a very important that we must outweigh the fits of the, we must outweigh the congenital anomalies. If the mother having the fits, then we must weightage the fits first, then the congenital anomaly. The risk to the mother and the fetus of non-compliance with prescribed medication. This should be discussed to the mother. The folic acid, 5 milligrams should be taken preconceptually, and it should be continued throughout the pregnancy because this is a drugs which are using in the epilepsy, they competed with the folic acids. So there may be the chances of the deficiency of the folic acid. That will lead to the neural tube defect. And we have to discuss the risk of epilepsy, that is a teratogenic effect to the offspring, 4% of the offspring increasing to 10%. ये अभी हमने बात की थी कि एक पेरेंट अगर सफरिंग हो तो कितना होगा, दो होंगे तो कितना होगा. Now, after the pre-pregnancy management, once the patient get pregnant, first we have to optimize the health of the mother. We have to optimize the dose of the anti-epileptic drugs. Is possible, we withdraw the drugs if the patient remain fit-free for the 2 years, or it's a better to, or otherwise we keep the patient on the simple single anti-epileptic which have the least teratogenic effect on the fetus, if possible. Otherwise, we can continue the similar regime. Then once the patient get pregnant, again, this should be the multidisciplinary. It should be seen by not only the obstetrician, but it should be seen by the neurologist, the nurse, the neonatologist. You must discuss with the neonatologist and anesthetist because she may require the anesthesia at any time. So the anesthetist must know about the health of this mother. Folic acid ideally it should be started prior to the pregnancy, and if not it started prior to the pregnancy, it should be continued from as soon as the patient come to you, that is in the first trimester, and should be continued throughout the pregnancy because there is a small risk of folic acid deficiency, folial megaloblastic anemia. There is no need to change the anti-epileptic drug. अब patient pregnant हो गई है, आपके पास आ रही है, तो आपका ये काम नहीं है कि आप उसको change करेंगे. If the epilepsy is a well controlled, अगर वो controlled है on the phenytoin, on the carbamazepine, on the sodium valproate, lomotrigine या किसी भी ड्रफिनोबार्बिटोल पे या किसी पे भी, अगर वो if the epilepsy is a controlled, then there is a no need to the change on that. ये risk ना लें. Restarting the anti-epileptic drugs. The many ज़्यादातर मैंने बताया कि patient जो होते हैं वो they may be stop the drugs because of the fear of congenital anomaly. So you have to discuss that your health is very important instead of this fear of congenital anomalies. Then we have to screening for the congenital. All these patients should be should come in the antenatal clinic as soon as she misses her period, and the first encounter is in the antenatal care. We discussed that you must do the ultrasound examination for the viability, for the number of the fetus, in confirmation of the pregnancy. You have to look for you take the history of the female, how many drugs she is taking, and what is the control of the epilepsy, whether how many fits she have in the month, and what type of the drugs she is using. If she not come into the pre-pregnancy clinics, then all the aspects which you have to discuss in the pre-pregnancy clinic, you must discuss in the first antenatal visit. You optimize the health, you advise the folic acid, certain multivitamin, and ask the patient to have the regular antenatal checkup. So you must have the screening for this on the knuckle translucency. You must have the knuckle translucency for the Down syndrome at the 11 to 14 weeks of the gestation. Then screening for the other things, which you have to do in the antenatal period outside the epilepsy. Those normal pregnant patients. All these things that like the blood CBC, the blood group, the viral screening, the urine analysis, the ultrasound, all these things should be continue in the patient in the antenatal period as those patients who are not epileptic. Then you have to, as we do the screening for the congenital anomaly, But it is better if you are going to do the screening for the congenital anomaly, that is the better time is 22 weeks. Otherwise, we can do 18 to 24 weeks, because these anti-epileptic drugs do causes the cardiac anomalies, and the cardiovascular system is completely formed at the 22 to 24 weeks. So it's a better to do the screening for the congenital anomaly screening. If we are going to do the anomaly screen, the best time is at 22 to 24 weeks of the gestation. So you may have able to detect the congenital anomaly of the heart. The drug level may need to be carried out as a routine, but many clinicians like a starting value and their situation that may be prompt testing. This depend upon, there is a controversy regarding the drug level, that the drug, you must assess that the drug, whether the therapeutic level is achieved or not. So, and how much, so as we discussed therapeutic aspects earlier. So the level of the drugs may be assessed, that whether the patient, on which level the patient has controlled her fits, and whether this much level of the drugs is teratogenic to the fetus. But this is a controversial, but some clinician may be having the drug level is at the start in the first antenatal visits to assess that what is the situation, what is the control of the patient, on which type of the therapeutic level the patient have the control on the her epilepsy. Then the oral vitamin K supplementation should be, patient should have the regular antenatal checkup as the others, and more frequently in the later third trimester, as we discussed in the other high risk pregnancies. This is again a high risk pregnancy. So she has the more frequent visits every 15 days, and then after 36 weeks, she should be hospitalized and for the delivery. And oral vitamin K supplementation should be given from 36 weeks onward, 10 milligram per day, to prevent the hemorrhagic disease of the newborn, because the certain drugs may have the effect on the population system that will causes the fetal hematoma and fetal hemorrhagic problems. Steroids, which we are going to give for the lung maturity of the fetus, because some hospital having the routine to give the steroids after this 34 weeks of the gestation, to prevent the lung maturity. If at any time this is a high risk pregnancy, she may require the termination or the induction of the labor, or all these high risk pregnancy having the low threshold for the preterm births. So we should give the steroids for the lung maturity. But if you are going to give the steroids, then the larger doses of the steroid should be given instead of the 24 milligram. We should give the 48 milligram in total. Otherwise, we give the 24 milligram in 2 divided doses, 12 milligram 12 hourly for 24 hours. But in the patient with the anti-epileptic drugs, we give the 48 milligram with the 12 milligram in the divided doses. So we must increase the dose of the steroid, because again this is because of the drug competitors. The drugs which are used in the epilepsy are competed the steroids. That's why their therapeutic value will be decreased. So we have given the larger doses. The relatives, friends, parents, or the husband, whosoever is looking after this lady, he or she must know how to place the woman if once she develops the fits in recovery position, that is the prop up in the left lateral position, to prevent the aspiration at the time of the seizures. So you must learn, the friend, her, the parent, her husband, or the person who is looking after to her, that whenever she develops the fits, the correct position to prevent the aspiration, inhalation, so she may not be choked at any time. Women should be advised, there are certain advice that she should not be dry. If she is going to having the driving anyhow, she must have the card, so that she is suffering from the epilepsy. what type of the drugs she is using. So this is very important. Either she should not be driving, or either if she is driving, she must have the card. If she is having the, as we are not having the practice of in our circumstances that we have the practice of the swimming in the swimming pools or any other areas. But if the women choose the swimming, then it should be in the shallow water, or it's a better to take the shower instead of the swimming in the swimming pools, because there may be the danger of the drowning. Now, intrapartum management. What is the intrapartum management? Should be not so much different from the other, is that you may deal the patient as usual, as that our aim is that the patient should have the vaginal delivery. The induction of the labor and the cesarean section should be only on the obstetrical ground. We only do the cesarean section or the rapid delivery of the patient, or the abdominal delivery of these patients if there is a hypoxia, fetal hypoxia or fetal distress. But it's a very important that the labor carries the high risk of the seizure. There is a more increased frequency of the seizure at the time of the labor, because there may be the sleep disturbance, there may be the reduced intake of the anti-epileptic drugs because of the delay absorption, there may be the hyperventilation, so that may alter the this may alter the free level of the anti-epileptic, and no doubt there may be the pain, labor pain, sorry, that may precipitate the seizures. So the every effort should be made to administer the anticonvulsant drugs as usual. Even if there is a delay absorption, you can give the intravenous phenytoin. So because if you are not going to give the anticonvulsant, patient may develop the seizure. So the seizures are if the patient is not taking, or you think that there is a delayed absorption, then you can give the rectally, you can give the oral, you can give the intravenously. So there's like benzodiazepine, you can give the benzodiazepine by the rectal route. Rectal diazepam can be used if the patient, you cannot give the IV. Status epilepticus and the recurrent seizure will lead to the cesarean section, and this is again only because of this is only the indication for the cesarean section, and this will lead to the fetal distress. That's why we will get rid of that fetus from that environment. So we do the rapidly the cesarean section. To limit the risk of precipitating seizure because of the pain, anxiety, the epidural analgesia can be considered. That it's better to give the epidural analgesia. This will causes reduce the pain, reduce the anxiety of the patient. You can top up it if you require the cesarean section at any time. Now the postpartum care, once the patient is delivered, when the patient is delivered, then there's a very important, never ever leave the patient as unattended at any time in the postpartum period or in the intrapartum period, because she may develop the fits at any time, and she may be aspirate, and there may be the sudden death. So in the postpartum period, as we know that the serum level of the anti-epileptic may rise in the postpartum period, as the monitoring may be necessary to prevent the maternal toxic side effect. Initially क्या होता है कि हीमोडाइल्यूशन होती है, तो एंटी एपिलेप्टिक ड्रग्स की जो थेरापेटिक लेवल होती है that is reduced, while after the delivery, as there is a anti-epileptic level rises, the patient may have the loss. So the toxic effect, and you may be adjust the dose of the anti-epileptic drugs. जैसे antihypertensive drugs की हम बात करते थे कि as soon as the patient get delivered, their blood pressure will be reduced. As soon as the patient deliver, sugar will be reduced. So the dose of the anti-epileptic drugs is also reduced after the delivery because of this hemoconcentration. All the anticonvulsants reaches the breast milk, so this is very important. So the sedation and the withdrawal effect should be observed to the neonate, but it is not very necessary that you must encourage the breastfeeding. It's not to stop the breastfeeding. The mother should be advised while certain strategies. This is a very important. Either the some person should be accompanied with a patient who is epileptic, that while she's feeding her baby, that she should be on either on the floor with a support, big support on the wall and the cushion around her, that at any time if she has the fits, she may not be over her baby and minimize the risk or the trauma to the baby. If she are going to change her nappies, she should be changed again on the floor. If she is a bathing to her baby, it's a better to the some person should accompany with her, or if she alone is bathing a baby, it's a better to bath the baby in the shallow water, so there may be the least chances of the drowning of the baby, or she may develop the fits at any time. It's a better to having the bathing in under the supervision of certain person, either her sister or mother or the mother-in-law or husband, so whosoever is living with her. Generally, the women should not be left unattended for first 24 to 48 hours, particularly. Meanwhile, this will be optimized. The dose will be optimized. What are the contraceptions? The contraception you must discuss. It's a better to discuss these contraception again prior to pregnancy. That you have to counsel the couple that they limit their size of the family, because because she may need the anti-epileptic drugs lifelong, so they may have effect on the fetus. So you must limit their family. It's a better to you discuss that what type of the contraception they can use. The contraception should be effective and potent contraception. If husband is a cooperative enough, then the condom can, but there may be the chances of the failure. So emergency ECPs should be available to these women. Those women who are using the hepatic enzyme inducing agents like phenytoin sodium, pyrimidone and carbamazepine, phenobarbital, they require the larger doses of, because they are the enzyme inducing, they compete the same enzyme as that of the estrogen. So the estrogen's efficacy may be decreased. So if the patient is going to use the OCPs or the estrogen, then she should use the larger doses of the estrogen. These all are the enzyme pill containing the COC which are containing the larger doses of ethinyl estradiol. That is a usual जो COCs होती हैं हम यूज करते हैं, उसमें 30 माइक्रोग्राम ethinyl estradiol आपको पता है, आपने कंट्रासेप्शन पढ़ा होगा, तो कंबाइन ओरल कंट्रासेप्टिव पिल्स जो होती हैं उनमें 50 माइक्रोग्राम ethinyl estradiol होता है, 30 माइक्रोग्राम ethinyl estradiol होता है, स्टैंडर्ड COCs जो होती है. But those patients who are on the anti-epileptic drugs, they should use the OCPs which contain the larger doses of ethinyl estradiol, that is the 50 microgram. This may still not be effective, and an alternate method of the contraception may be appropriate. Even the 50 microgram may be sometime not be effective. The efficacy of the POPs is also affected by the enzyme-inducing anti-epileptic medication. So the patient, if going to take the POPs only, the progesterone only pills, that she should take the 2 rather than 1 pill a day. Or she again take the larger doses of the POPs. Medroxyprojection, Depo-Pyruvara effective and larger doses are not needed. क्योंकि ये injectable है, oral नहीं है, तो first pass effect होता है enzymes का. So this will not be depend on the enzymatic activity. So the injection are the better as compared to the. Again, the morning after pills, that is the emergency contraception, can be used, but larger doses, double the dose. If the patient is taking 1 tablet, she should take the 2 tablets. She is taking 2, she should take the 4 tablet. Now, what are the points to be remembered in the epilepsy? This all the women receiving the anti-epileptic medication should receive the pre-pregnancy counseling. ये मैंने पहले भी बताया. She should take the folic acid. Mostly the anti-epileptic drugs are teratogenic. You have to counsel the lady regarding the teratogenicity. The risk is lower on the monotherapy. So better to keep the patient on the monotherapy as compared to the multitherapy. Risk is higher with the sodium valproate acid. Prenatal screening for the congenital anomalies. ये तो हम सब में करते हैं, पर इसमें बहुत ही ज़्यादा important है कि आप 22 to 24 weeks पे particularly the neurological and the cardiac anomalies should be assessed. In women, the frequency of the seizures is not altered by the pregnancy, provided there is a compliance with the anti-epileptic drugs regime. Drug-free level tend to fall in the pregnancy and increase the dose of anti-epileptic drugs may be required. इन्हें बताया कि हीमोडाइल्यूशन 50% प्लाज्मा वॉल्यूम इंक्रीज होता है प्रेगनेंसी में, तो थेरापेटिक लेवल तो रिड्यूस होगी ही ना नेचुरली. विटामिन के 10 to 20 milligram, जैसे मैंने बताया कि after 36 weeks to prevent the hemorrhagic problem into the neonates. Breastfeeding should be encouraged. Hepatic enzyme inducing drug reduce the efficacy of the contraception, particularly the hormonal contraception. So the combined oral contraception pills should be given with larger doses of the ethinyl estradiol, or maybe require the double dose of this contraception. Or it's better if the patient having completed the family, then they maybe choose the permanent method of the contraception. Thank you very much. And now this is a period of question and answering. Is there any question? Someone raising their hands. So can you ask the question now? Are you hearing me? Are you hearing me? आवाज नहीं आ रही?
मैम आ रही है आपकी आवाज.
आ रही है? बीच बीच में कोई क्वेश्चन रेज हैंड कर रहा था. नाउ यू कैन आस्क द क्वेश्चन बेटा.
Which drug is best for the epileptic fits?
As I told you already, all the drugs. It's not a base drug. We do not say that the base drug. Base drug is the drug which have the good control on the epilepsy, because the mother is very important to the then the fetus. That's why we, as I discussed that all the patient with a medical disorder should be multidisciplinary. The pregnancy should be planned. It should not be accidental. So all the patients should optimize their health. So it's a better the patient who have the control on their fits for the 2 years. अगर किसी भी patient के 2 साल हो गए और उसको कोई fit नहीं पड़ रहा है, तो it's a better to stop the drugs, because particularly in the first trimester, because all the drugs have the some or large effect on the fetus, either the minor congenital anomalies or the major congenital anomalies. So we cannot say which one is a safer. All have the teratogenic effect. But the importance is which drug is a better control. That's important. Any other question?
Thank you, ma'am.
Any other question? Someone was raising their hands. No question? Can we stop?
Yes, ma'am.
No, ma'am.
Okay.